Okay, so I don't know how to follow that introduction because I don't know if I can live up to all that stuff. So I'm going to talk about the Affordable Care Act today, and I guess the first thing I want to say is the Affordable Care Act was not what everybody thinks it was. It's kind of been a try for the last 30, 40 years. So the origination of the Affordable Care Act actually came up in the Nixon administration, and it was one of the things that Nixon ran on. And so a lot of people think, oh, it's just an Obama thing and maybe a Clinton thing, but it actually has been being batted around for years because healthcare is really not affordable. And so what it did was it looked to create three things. One, it wanted to create, and we call it the triple aim. So the triple aim of the Affordable Care Act is we want to have access. That's the number one thing. We want to change the cost structure, and we want to make sure that there's quality health care. So access to quality health care that doesn't cost a lot. That's the aim. And so the Affordable Care Act, as everybody knows it, has kind of gone into effect in the last year, maybe 2 years. And so what's happened is that we've created access, except in Florida, because Florida didn't expand Medicaid. So the states that expanded Medicaid actually increased their access a lot, so that the 47 million people that weren't insured those numbers have gone down significantly. What is the overall result of that? Well, with these people that are now being insured, last year hospitals actually had profits that they never had before. So for the hospital systems, the Affordable Care Act has actually been a really good thing, because in the past they were taking care of patients for free. So that they didn't have to write stuff off anymore. They were able to actually now make a little bit of a profit. And then for the nonprofit world, they still made some money, so that they can now share that with the rest of their communities. So that the big thing that we are all told is it was going to take care of all three of those things: cost, quality, and access. The reality of the Affordable Care Act is it only took care of one thing, and it's based off of the Massachusetts model, which was Mitt Romney Care. And in Mitt Romney Care, over the past 6 years that they've been running the Romney Care program, 10 years that they've been putting in the works, they have only changed the access. Costs actually went up. And that's what we're seeing right now on the federal side, is that costs are going up. So that the average company that buys insurance this year actually paid 10% more than they paid last year. So my personal story, I had my own personal health insurance, and I was paying $340 a month. And my insurance, when I went onto an Affordable Care Act plan, because my plan didn't meet all of the necessary standards of the Affordable Care Act, went up. I had a $1,000 deductible, now I have a $12,000 deductible, and I now pay $980 a month. So has the Obamacare Affordable Care Act taken care of the cost problem? It really hasn't. And what they did was they addressed it for certain people, because certain people can get subsidies. If your state was making something, in order for your state to get subsidies from the federal government, it had to create its own exchange. Florida did not create an exchange. So that pushed us out of being able to get subsidies. So it didn't necessarily help a lot of the people that it was intended to help. And it actually hurt a lot of people that are middle class, because now their cost sharing has gone up. So if I want to go in now for a visit, I have to now pay $12,000 before I actually get my coverage. And then I have to split with my insurance company 50-50, so they pay 50% of the bill and I pay 50% of the bill. So what's happened is we've just taken and we've pushed off costs onto other people. So it hasn't worked on the affordable side. It hasn't worked on the care side. The quality of care was never really addressed the way that it was supposed to be addressed. And to increase quality, one of the big places that we have to increase quality is hospitalization, because that's where all our cost goes, right? You're in medicine. So when we talk about cost, the biggest cost that we have is in our senior population, and the biggest place that we have costs is in the hospital world. So what we're trying to do is we're trying to take it so that people that go into the hospital don't come out and not know what they're doing and then go back into the hospital. That's where all of our costs are. About 80% of our costs are in hospitalization, rehospitalization. Not in what everybody thinks. Everybody thinks it's drugs, it's devices. It's in hospitalization, rehospitalization. So where's the problem? The problem is that when they get discharged, people leave and they don't really understand their medications. They don't understand what they're doing with their medications. They're not really sure of how they're supposed to be handled. Sometimes they get back to their primary care. Sometimes the primary care helps them with things that they have to do, but the primary cares are overwhelmed. There's not enough primaries. One of the things we learned with the Affordable Care Act is that we were going to need probably about 100,000 more primary care physicians within the next couple of years in order to be able to handle the new load of people that are going to come to them. So we started to create an administrative area where we created what's called accountable care organizations. And in these accountable care organizations, we created a new role, an administrative role, that's not funded by Medicare. So what we did was we raised the cost of healthcare for the provider. So now the provider is paying more in order to actually be able to manage the care, which they should have been doing in the first place, but they're not getting any reimbursement for that. So we're struggling on the cost side. And where we've shifted the cost is into people like us and people like our physicians. The insurance companies, they're just pulling in the money and they're making the same profit because that's the deals that they've made. The hospitals are actually making a greater profit, but the place where we're really falling in is in the outpatient physician world. So how has the Affordable Care Act dealt with the hospital situation? Well, they've basically said to the hospitals, we're going to measure you on different things that you are supposed to be doing. And we're going to do that through what's called EMR. And so they've put into place where physicians can no longer have paper and pen notes. Now, I personally think that's a great thing because a lot of problems are in the fact that people are writing and nothing can be read, especially doctors, right? So what we did is we created an EMR system. And the problem with the EMR system is that Florida Medical has a completely different EMR system than I have. I have a completely different one than Florida Hospital. Florida Hospital has a different one than Tampa General. So all of these EMR platforms don't talk to each other. And so we still run into this collaborative problem where we're not able to collaborate physician to physician. If I wanted to send my notes to Julie, and Julie was treating one of my patients and she wanted to get her notes to me, we'd literally have to call each other on the phone and go, I'm going to fax this over to you. And that doesn't make any sense. So the problem that we're running into is that nobody's talking to each other. And because no one's talking to each other, quality of your care or your parents' care or your friend's care is going down. So if I go to the hospital and one doctor is seeing, you go to the hospital, you may have 10, 12 different physicians. Kim and Bob were recently in a place like that. And none of those doctors actually are collaborating with each other. They're all walking in and going, okay, let me see. And they write something down and then they leave. And then they get a visit for that. And then they write down something and they leave. And no one's really talking to each other about managing the care. If you don't have somebody there that understands the medical system working with your family member, you're going to be really in trouble. And we were lucky when you guys were in Tampa General that our primary care doctor was actually there. So he was able to walk them through the landmines that they were experiencing. And it makes it a little bit easier. But that's really what we need in our world, is we need to somehow work on collaborating across lines so that if a patient goes to the hospital, when they come out, that they're being managed by all of the people that need to manage them, and everybody has an instant communication with each other so that we keep them kind of hugged into our world. Otherwise, they end up right back in the hospital. And when they end up back in the hospital, there's chances of nosocomial infections or hospital-acquired infections. There's all sorts of things that can go back wrong on that patient. So our struggle in the Affordable Care Act is to figure out how do we get quality. And one of the places that we have to really start looking at is in that EMR-based system. And overseas, what they've done is they've created a credit card, right? So they basically have a card that carries all of your personal healthcare information, and you walk into the doctor and you put it in the machine, and it reads all of your stuff because it's all kept in the cloud. Right? This fancy cloud, I don't really understand what that is. But they put it in the cloud, and then the doctor pulls up your file, and then they do all of their stuff, and then they download it back into your card, which also downloads it into the cloud. So when you walk into the next doctor, you put in your card, and they can pull up all your information. All of your medications, everything you've done, your entire health history is on. Imagine if you didn't ever have to give your health history again. How many times do you walk into a doctor's office and have like 30 pages of stuff to fill out all the time, right? And it doesn't make any sense. And so we constantly are going to different places, giving the same history over and over and over again. And what's happening is, this guy's not talking to this guy. They have a system for your medications now that you enter everything and it goes directly into the cloud. So, you know, my chiropractors have to make sure that they're hitting on these things and making sure that's part of meaningful use. We have to make sure that the medications are uploaded into the cloud so that the pharmacists anywhere in the world can see those. Well, wouldn't it make sense if your primary care gave you a medication that they uploaded into the cloud as well? It would, right? And wouldn't it make sense that your rheumatologist loaded something, and your oncologist loaded something, and your heart management guy loaded something, and your lung man, because we all have 50 doctors, right? Especially over the age of 50. So you're getting 60. All right. It's going down. Yeah. More and more people are on more drugs now than ever before. The average senior citizen is on 12 different medications, right? So the management of those medications is pretty tough. And so what has to happen is we've got to make sure that there's cohesiveness in the system. And so we'll go into people's files, and we're on the same platform. That's the one place we're actually right, is we have a platform for prescription drugs. And we go into people's files, and they give me a list that's 20 different medications, and none of them are loaded into the cloud. So we're missing stuff, and that's how drug errors happen. That's how medication errors happen. According to the Journal of American Medical Association, they extrapolated this number, but they say that 125,000 people die every year from medical errors based off of properly prescribed medications. Just medication, and medication errors added into that is over 1 million people, which means that more people die from medication errors than heart disease. That's crazy. That doesn't make any sense. So we're making mistakes because we're not using our EMR platforms the way that we should, because they don't talk to each other. Now, part of it is the American way, right? Because we shouldn't say this company can't make an EMR, and this company can't make an EMR, and this company can't make an EMR, and this company can't make an EMR. It's because I should be able to have choice of what I want, how I want to run my practice. But there needs to be a place that stores all of the information so that everybody has access. So if I like the way my platform looks, I can keep it, and maybe there's a cloud up here that it just uploads it. And then you get a card that stores it, so that you can walk into any doctor and go, here's my stuff. I don't have to write it down again, right? Wouldn't that be nice? That would be so nice. That doesn't exist. And it doesn't exist because all we ever do is fight. And so now, the way that we're going to decrease costs, this is how Medicare has decided they're going to decrease costs. They've decided that they're going to measure doctors on things called meaningful use, and another thing they call PQRS, and another thing called surveys. So it really started in the hospital world, but it now has traveled down to every doctor. So every doctor, every physical therapist, every chiropractor, every medical doctor, it doesn't matter what specialty you are, you're all measured on this meaningful use. Now, it's a great idea, because wouldn't it make sense that if you came into the office and you took your blood pressure, that it popped it, that we made sure we did it, and somebody was staying on top of the fact that we took your blood pressure? That would make sense. But it's never really put anywhere. It's only stored in your system, and then you send a little note to Medicare saying that you actually accomplished it. It's never going anywhere. It doesn't. My meaningful use never talks to your primary care. So if I'm not your primary care, and you come into me for a problem with your knee, then what happens is I take all this stuff, and I may find something that if I don't make a phone call to your doctor's never going to know unless you go tell them, which you're not going to do, because nobody does. Especially when you go to the chiropractor. People go to the chiropractor, they don't tell their doctor. The doctor's going to be upset about that. So it's a struggle. And if you go to the chiropractor, usually you don't tell them about the medications, because you go, well, that chiropractor's not going to like that I'm on medication, so I'm not going to tell them that. Well, maybe the chiropractor then gives you a supplement, which then interferes with your medication. So we've got a real struggle. Imagine if it was just stored on the cloud and we could all just look at it and go, let's talk about this, because everything that everybody's doing is working to help care for you. So they created this program, and really what they did is they said it was an incentive-based program. The reality of the program is that by 2017, the average hospital will be losing 17% in their Medicare reimbursements. Now, the average hospital makes 4% in profit. 4%. So if you take away 17%, what's going to happen to the hospital system? It's going to collapse. It's going to collapse. And so you're going to end up with hospital systems that can handle things like that, and they're going to buy all these other hospitals, and there's going to be less hospitals, and eventually you'll have one solid hospital system. It kind of sounds like we want to have single payer. We also want to have single system, right? So we're heading in that direction because of the things that we're making as ways to punitively go after the hospitals. And it makes no sense because now we're dropping that into the primary care practitioners who are already struggling to pay their student loan debt. So nobody really wants to go into primary because there's no money in that. So what they're doing in primary care is they're creating what's called capitated health care, which means that a primary care doctor gets 3,000 bodies sent to them, and they're responsible to take care of everything that person does. And if that person comes in a lot, then they make less money, and if they come in very little, then they make more money. That is a really bad way to incentivize primary care, because then they're not taking care of you. The other thing that the Affordable Care Act talks about is health, actual health. How do we get people healthy? So we created these wellness checkups. The problem with that is your primary is not capable of handling a wellness checkup because they're there for acute care. They're there for chronic disease management. But they don't get health care in school. They don't understand health care. We've really got a sick care system. We have a terrible health care system. I think it's a misnomer that we call it the health care system. We really should call it the sick care system. And what we should be paying for is sick care. And maybe we should also be getting bonuses if we keep ourselves healthy. But what we've done is we've said, well, it doesn't matter how sick you are. We're going to make sure we take care of everything you could possibly need over here. And we're going to talk about healthcare till we're blue in the face, but we're not actually going to teach you about what you should do to stay healthy. And therein lies the problem, because now your primary care is responsible for your health, but they don't know how to get you healthy. So what do? You have high blood pressure, they put you on blood pressure medication. You have high cholesterol, they put you on cholesterol medication. You have diabetes, they put you on diabetes medication. What's everybody dying from? Those three things. So we have to start opening up the dialogue to talk about what we can do, not just in the sick care arena, but create an actual healthcare arena. And where should that happen? It should happen through public policy in looking at what's happening in the world of education, right? Imagine this. We have Common Core in Florida now, right? For our kids. What does that mean? We focus on reading, writing, and arithmetic. So we've gone backwards again. We got rid of the arts, we got rid of actual, there's schools here that you don't have gym for your kids, right? The public schools, age 0, 0 through 6th grade, no recess, right? You guys know this? A lot of these schools they're getting rid of recess for their kids. They're getting rid of physical education. And what's the #1 problem in America today that's causing health problems? Obesity. Yet we're getting rid of, we took the sodas out of the schools and we replaced them with Gatorade. Right? I mean, really, there's more sugar in Gatorade than there is in sodas. So it's not like we've changed anything. All we're doing is we're taking these kids and we're educating them, we're sitting them on their butts, and this is what they're learning. And then so the obesity epidemic is getting worse and worse and worse, and we're not doing anything about it. And that's a public health problem that's leading into the sick care problem. And so we have we have adults that are struggling, and then we're teaching the kids to do things worse than we learned. And we've got worse opportunities today. So when I was young, I think my mom took me to McDonald's, once a year when she took me to the doctor and they gave me a shot. It was a treat. Today, I have patients that literally go to McDonald's every day. And it's not that McDonald's is bad, it's just that you can't do that stuff every day. The movie Super Size Me taught us that, right? So if you get anything, you can get stuff from the movies. So the reality is we're doing things that are creating a sick care arena. And when we keep creating this sick care arena, we're never going to get out of the woods that we're in right now. We're at 18% of GDP today. That number in 2023, they say it's going to be up to 28%. 28% of GDP. That is not sustainable. We can't keep pumping money into this sick care system. As the society ages and the replacement society gets smaller and the financial burden is pushed over into this smaller society, we're in real trouble. So what do we have to do? We have to start looking at how do we change public policy. Where should it start? It should start in the education world. We should be taking Common Core and adding one thing. Imagine if we took and we said, okay, 5 days a week our kids are going to learn about health. right? Because if we don't have health, everything else falls apart, everything. And so we have to start thinking that way. Instead of what the Affordable Care Act says is, go to your primary and they're going to teach you about healthcare. They're going to get you healthy and well. They're not going to get you healthy. They're not healthy and well themselves. So we have to start creating policy in the public health arena as opposed to this big, massive balloon, nobody knows how many pages Affordable Care Act. Because nobody really knows how many pages the Affordable Care Act is. It's actually a couple different things. So they had to reconcile it after they actually wrote it. And so there's estimates that say it's 10,000 pages. There's other estimates that say it's 60,000 pages. To me, that's a little scary that we can't even tell how many pages this thing is. But the reality is, fixing the Affordable Care Act is almost as simple as changing the way we think about health care. So what we've done is, we have created a system where we're innovating healthcare. And we're looking at how do we get people in on a primary care level and teach them in a 6-week program about how to be healthy. And so how do we create wellness as opposed to sickness? That's where we have to change our focus. And the Affordable Care Act talks about it, but if we don't start changing the way we think, we have to go make a complete 180 from where we are. If we don't start to change the way we think about it, we're never going to get there. We're just going to keep pushing people further and further into the sick care system, which is going to increase cost. Quality is going to go down because cost is going up. There's no money for the practitioners. The people that are going to go into medicine are going to be not the smartest anymore. They're not going to be the best because there's no money. If there's no money and they can't pay their student loans, why would anybody want to go into healthcare? There's no reason for it. And the problem that we're running into is the only thing that anyone wants to pay for is things that make tons of money, which is surgeries, things like that. So we're not looking at how do we keep people well. We need to pay to keep people well, to keep them out of the sick care system. That will lower the cost curve. And so the cost curve shifts by changing public policy. So access, absolutely created through the Affordable Care Act to a point. It's decreased it for people like us, maybe. You know, middle-class Americans, actually, if your deductible goes up and you have to pay every time you walk in the door, you may go less. It's increased it for people who are a little less fortunate, so now they're going to be able to go to the doctor where maybe they didn't before. So, and they're taking away the Cadillac plans as of 2017, which means that the unions who've created all these different benefit programs are basically going to get a real slap. So there's going to be real trouble in a couple of years as far as the Cadillac plans that actually pay for all sorts of things. So access has arguably gone up, more people are insured, but does that really mean that more people are actually going to be able to go to the physician or going to be able to, or going to want to go to the physician? Quality, nobody really knows what's happening in quality. The ACOs, the accountable care organizations, they've never proven that they've actually increased quality yet. It makes sense if they can actually start figuring out a way to collaborate. What we do in our office is we have a system, and inside the computer system it collaborates. The problem is when they get outside the system. Now we have what's called a personal client advocate, which means that every person that walks in is given an advocate that makes sure that your care is communicated throughout, no matter where you go. Whether you go to the hospital, whether you go somewhere else, we communicate with you, we collaborate with your family. So, but it's expensive, and insurance doesn't pay for that. So the question is, how do we improve the access, the quality, and the cost? And cost is always a struggle, because when one person's cost goes up, another person's goes down. And so if you start taking and making insurances less money, then they're going to start hitting the physicians. And so there's this constant battle with cost. And the biggest problem in cost is that we have no transparency. And with no transparency, we have no market, right? So if you want to go buy a bottle of water, you go in there and you go, oh, it's $3.25. I decide I want to buy that, or I want to buy $1 bottle of water. But if you go into your doctor, nobody has any idea how much it costs. And it costs different if you have good insurance or if you have crummy insurance. It costs different if you go to the hospital or if you go to your primary care for the same exact thing. I've had patients come to me, they've been to the hospital and they got an x-ray and they charge them $10,000 for an x-ray, which I charge $100 for. So there's no transparency in healthcare, which means that you can't have a market. The other part of that is that you don't actually pay for your healthcare except on the back end. Your insurance company is making the deals. So how can we have a marketplace that we can't really have a market? So we've got to start thinking a little bit differently and innovating healthcare. How do we keep people healthy and well? create innovative programs that are going to keep costs down. Here's an example. We, in our company, decided that one of the places that was the biggest problem was seniors. So with seniors, one of the biggest problems is they can't move around real well. So when they're moving around, they can actually exercise, they can lose weight, they can keep their blood pumping, they can do all these other things. So one of the problems that we're having now is we have an influx of knee replacement surgeries. And as knee replacement surgeries are going up, we're getting more people being hospitalized because of infections, and they're really expensive. So the average knee replacement surgery is about $105,000 to $108,000. So what we did, we said, let's get seniors moving. We can create a program which incorporates physical therapy with an injection of what's called a Halgan cartilage. And what it does is it puts a space in the knee, and it increases the space so that you have a shock absorber. And now, over a 6-week period, you increase your muscle tone. We also look at balancing your hormones, making sure you lose weight. Over a 6-week period, our success rate so far has been 100%, and it costs $3,500. So for $3,500, you can get basically the same thing as that knee replacement surgery. So the question is, why are we not looking at more innovative solutions to keep people healthy and well? That's the point we have to get to. And if you're going to be doing those things, and if you're going to be doing knee replacements, why are we not also sitting them down with a nutritionist at the same time? Because if they wore it out, the chances are pretty good that they're overweight, they've got other issues that they're dealing with, and we need to start looking at the whole picture as opposed to just a small part. So that's kind of my crux of the Affordable Care Act. It's not necessarily affordable yet, we're not really increasing the quality yet, and we haven't done very much at all as far as communication, collaboration, and the cost is just going through the roof. So is it going to bring us what we think it's going to bring down the road? It's here to stay, that's the reality. They're not going to repeal the Affordable Care Act, it's too many pages. I mean, I don't think they know how to do it. But the reality is, we have to now define how do we fix our broken healthcare system. Because it is broken. And the answers are maybe to look towards Europe, maybe you look towards, everybody's looking towards Singapore. I don't know if you guys have read Ben Carson's book, but Ben Carson talks about Singapore. The problem with the Singapore system, it is the most affordable system in the world. They do have quality, they do have access. The problem is that it's based on the same Ponzi scheme that Medicare was based on. So now they're running into a problem where their society is aging and they're having to actually pay their younger people to actually have kids in order to feed the system. That's probably not a good idea in America. So, Dr. Tim Bain.